My patient, 11-year-old child, Miss Akshita Reddy, hailing from Nagar Karnool, studied up to first class, now presently at home. Informant being mother, she is a known case of CKD-5D on MHD, on maintenance hemodialysis since 1 year. She now came for access creation.
The age of the patient is?
11-year-old child. I will, history of present illness. I would like to date back my history when child was 10 years of age on October 2022. When the child has a history of vomitings for 4 days, which are 5 to 6 episodes per day, non-bilious, which had increased with taking water and food and associated with nausea, and no history of blood in vomitus or abdominal pain or loose stools. Child also has a history of fever, which is for 2 days, which is low grade, not associated with chills and rigors. There was no history of rash or bleeding manifestations, and there was no history of cough or pain during micturition. There was no history of headache or seizures. There was no history of pedal edema, facial puffiness, no history of any decreased urine output, hematuria, or passage of dark color urine. And child was initially treated symptomatically with antipyretics at a local hospital, and after blood investigations and parents were told that the child has a renal dysfunction, and she was told to go to higher center, and child came to the private hospital in Hyderabad, after which the child underwent investigations, and she was told that she has small kidneys and she has renal failure, and she was also the parents were also informed that the child has high BP recordings, and she was started on oral antihypertensives, and the details of which the mother couldn't recollect. And child was advised for peritoneal dialysis initially, and she was placed on a rigid catheter for 2 days. And later she was advised for CAPD catheter insertion, soft PD catheter insertion. And as per the mother, the procedure went uneventful, and child was started on exchanges with the cycler on the next day for 7 days. As per mother could not recollect the prescription, and child was symptomatically better and tolerated the prescription for the 7 days. And due to financial constraints, the parents were taken the child to NIMS, and a mother was given. At NIMS, mother was given training to give manual exchanges, and the PD prescription, as remembered by the mother, was it was daytime manual exchanges, and there were 3 exchanges per day, 1000 ml each, and the dwell time was 4 hours, and ultrafiltrate, as per mother, was 800 ml, and at that point of time, the child has no history of pericatheteral leak, and there was no history of pedal edema or facial puffiness. There was no history of abdominal pain or fever or cloudy precipitate or effluent, or no history of constipation. Child was symptomatically better and was discharged after 20 days with antihypertensives and calcium and soda bicarbonate prescription. And child was in regular monthly follow-up with NIMS, and she was advised to continue the same prescription for the next 8 months, and child was asymptomatic during this period. On May 2022, and child has a history of abdominal pain for 2 days, which was increased on doing exchanges, which was diffuse and non-colicky pain, and child discontinued exchanges after this episode, and there was no history of loose stools, and child has history of fever for 2 days, which was high grade, associated with chills and rigors. There was no history of pus from the PD catheter site, or no history of any cloudy effluent or passage of pus from the site. And child has a history of shortness of breath on exertion for 1 day, and she was taken to a local hospital for which she was symptomatically treated and referred to a higher center. Child went to Osmania hospital, where the child was evaluated and told to have infection in the abdomen, and fluid from the peritoneal cavity was taken for investigations, and child was started on intraperitoneal antibiotics as per mother, and the dose and the name of the drug she doesn't know. And after 2 days, child was symptomatically better, and the fever spikes and abdominal pain reduced. She was told the infection was decreased after and antibiotics was continued for another 2 weeks. At this point of time, child was started on hemodialysis through right IJV catheter, non-tunnel catheter, and she underwent alternate day hemodialysis sessions for the next 20 days. After this, the child was started on exchanges again through the PD catheter, and after which she again complains of fever, which was high grade associated with chills and rigors. There was no history of abdominal pain or cloudy precipitate at this point of time. And child was advised for catheter removal at this point of time. But parents were not willing, and they wanted to take second opinion, and on June 2022 they came to NIMS for further management. And she was placed on in NIMS, she was placed on right IJV catheter and started on hemodialysis, and CAPD effluent was sent for investigations. And after 5 days, patient was told that the infection was persistent and advised for the removal of the PD catheter, and catheter was removed. Right, child was advised to undergo lifelong hemodialysis, and right radiocephalic AVF was created, which was failed after 2 days, and child underwent left BC AVF creation after 1 week after this right RC AVF. During this period, child has decreased flow in the right IJV catheter. The right IJV catheter was removed, and child was placed on the left femoral catheter and undergoing dialysis for another 5 sessions of HD. And after which child was told to have a decreased flow in the left femoral catheter, and she was placed on right femoral tunneled catheterization and was discharged. She was advised to continue twice weekly hemodialysis sessions at local center, and she was discharged. After 1 month after this discharge, she again.
Short case. You have to summarize and complete within 5 or 10 minutes.
Almost. After 1 month after this, child has again decreased flow in the right femoral perm cath. So she again readmitted, and she was placed now on left femoral catheter for now, and underwent dialysis for 2 sessions. And after which child was started on left BC AVF with and underwent 2 sessions of HD through the left BC AVF. There was no history of fever and chills during HD, and there was no history of intradialytic hypo or hypertension. The intradialytic weight gain was 0.5 kgs, and residual urine output was 1.5 liters, and she was taking injection EPO. There was no history of blood transfusions, and she was vaccinated with hepatitis injection, and she is on supplementation with calcium and soda bicarbonate and 3 antihypertensives. Parents were counseled regarding the plans of transplant and being investigated for the same. Past history. Past history, antenatal history. She was born out of non-consanguineous marriage. She is second in birth order. She was conceived spontaneously. And first trimester, second trimester, there was no history of fever, no history of any drug intake by mother, no history of any high BP recordings, no history of any gestational diabetes, no history of pregnancy-induced hypertension or polyhydramnias, oligohydramnias. And she underwent 1 antenatal scan, which she was told it was normal. During the third trimester, there was no history of PAH or gestational diabetes. There was no history of oligo or polyhydramnias. She was delivered by normal vaginal delivery at term gestational age with birth weight of 3.5 kgs, and she cried immediately after birth. There was no history of NICU admissions. She passed urine within 24 hours and stools within 48 hours. And developmental history. Coming to developmental history, child motor and fine motor, language and speech and social were up to the age, milestones are up to the age, and the scholastic mother told up to schooling it was normal up to the age. She was vaccinated as per IAP schedule. Bowel and bladder control attained at 8 years of age. In the past history, there was no history of recurrent UTIs or excessive cry during urination. There was no history of any lower urinary tract symptoms. There was no history of poo stream of urine or recurrent fevers, passage of foul smelling urine or cloudy urine. There was no history of any surgeries. There was no history of any bony fractures or bony pains. On further probing mother, she told there was history of polyuria. Increased frequency of urination. Child goes to toilet every hour. At night she goes to around 5 to 6 times per day. There was due to which there was a history of sleep disturbances, and she stopped bloodletting at around 8 years of age. Family history, she has an elder brother, 13 years of age. He was born out of normal vaginal delivery, 3 kg birth weight, and no history of similar complaints in the family members.
Complete your examination findings.
On examination, child was conscious, coherent. She was moderately built. There was pallor, no icterus, no cyanosis, clubbing, and pedal edema. Height of the child was 124 centimeters, less than 10th percentile. Weight of the child was 21 kgs, less than 5th percentile. BMI was 13.7 kgs, less than 5th percentile. And mid-arm circumference was 16 centimeters. General examination, there was no frontal bursing. Ribs, there was no rachitic rosary, no Harrison sulcus, no dental caries. No swaying of wrist. The intermalleolar distance was 2 centimeters. Intercondylar distance was 6 centimeters. Mild varus deformity was there. And there were healed scars over right side of the neck, left femoral and right femoral sides, and CAPD catheter insertion mark was there, and left RCAVF scar present on the hand, and the left BCAVF examination, the segment was appreciated, thrill was felt, pulse augmentation test and arm elevation test was normal, there was no aneurysms, there was no warmth. Pulse rate 90 beats per minute, BP 100 by 70 mmHg, in the right upper limb, normal volume, normal rhythm, no radio-radiate or no radiofemoral delirium. All peripheral pulses are felt equally.
Any positive findings on systemic examination?
Systemic examination, no ma'am, no scar, no ma'am. Genitalia were normal. CNS, no tuft of hair, no dimple over the spine, no spinal deformities. Fundus was normal.
BP was normal?
BP, according to nomograms, it was more than 90% also. On 3 antihypertensive drugs. She was already on antihypertensive drugs.
What other findings to be specifically mentioned when in a pediatric CKD?
From antenatal history, we have to take maternal history of any drug intake, maternal oligohydramnias, PAH, GDM, and drug intake, whether mother has taken folate supplementation or not.
For this particular case, what is the likely maternal history that we expect?
Oligohydramnias, oligo or
Is it
polyhydramnias?
oligohydramnios?
Polyhydramnias. Oligo or polyhydramnias. Any obstructive features are there, then we will get Potter's oligohydramnias.
Or bilaterally hypoplastic kidneys in the fetus
can have
oligohydramnios.
Oligo, not
oligo.
Isn't it? For a concentrating disability of the fetal kidney will produce polyhydramnios. Okay,
Yes,
then.
And we have to gestational diabetes, history of gestational diabetes, fetal toxins like anti-epileptics, history of any anti-epileptics or alcohol intake.
Are we interested to know the birth weight of the child?
Birth weight, yes ma'am. Low
How will you
nephron
correlate
dosing.
birth weight to the CKD by 11 years of age?
Nephron dosing, ma'am. If preterm birth, usually the number of nephrons will be the nephrogenesis will be completed by 36 weeks, ma'am. If any preterm, 28 to 36 weeks, there is only 1/3 of the nephrons will be generated. After that, only after 24 weeks to 36 weeks, the remaining nephrons will form. So any preterm birth, so we can.
So patient is admitted to the neonatal ICU and you are asked about the choice of antibiotics. Do you have any specific?
Amikacin and aminoglycoside should be
Because
avoided.
their nephron growth may continue for 6
and
weeks after delivery also.
Yes, ma'am.
May not have a new nephron formation, but further development may continue. So avoid aminoglycosides in the immediate postpartum period, the neonatal period.
And history of NICU admissions or any.
Okay. Then after birth, what are the other important histories to be evaluated in this child?
In this child,
This is CKD by 10 years of age, isn't it?
we have to ask regarding
You said recurrent episodes
UTIs,
of recurrent UTI.
UTI, yes,
You have
ma'am.
already mentioned
Yes,
that. Then
episodes of recurrent UTI and lower urinary tract symptoms or
lower urinary tract symptom, nocturnal enuresis,
nocturnal enuresis,
dribbling of urine, wetting of the underwear, etc.
Yes, ma'am. Bladder and bowel
Suspected
control.
neurogenic bladder.
Yes, ma'am. And at the
Any
admission,
surgeries done for
Surgeries.
meningomyelocele to rule out any, etc. Then
neurogenic bladder.
then
Spinal deformities and tuft of hair, dimple of hair. Like
okay, that is for
neurogenic
examination purpose. Then
bladder. And
polydipsia, polyuria,
urea. Yes.
indicating classical symptom of nephronophthisis,
Nephronophthisis.
isn't it? Then
Mm,
episodes of metabolic acidosis, frequent hospital admissions for intercurrent illnesses with disproportionate dyspnea, suggesting metabolic acidosis. They are more prone for metabolic acidosis, isn't it? Then
mm,
if the child gives a history of disproportionate anemia requiring blood transfusions,
and growth restriction.
what mutation you suspect?
HNF 1 beta. Oh,
Disproportionate anemia in 10-year-old child presenting with CTID, renin mutation, classical presentation of renin mutation.
Renin mutation.
Renin mutation. Okay. So what is your diagnosis in this child?
CKD 5D on maintenance hemodialysis. Native kidney disease presumed CI and CKD. CAT could most probably
CKD due to CTID.
CTI.
Cause of CTID here?
CAT could ma'am, presumably.
Catcoat. Where is the evidence for catcoat in this history? Huh?
Most common.
What do you think the cause of
Second will
CTID
be
here?
juvenile nephronophthisis.
Nephronophthisis, classical presentation of nephronophthisis,
Nephronophthisis.
isn't it? CKD, CTID, possibly due to nephronophthisis.
With multiple
GFR stage, G5D,
G5D, 5D.
albuminuria, you can't assess at this point of time. This is the diagnosis, isn't it? Okay, how will you continue with investigating to confirm your diagnosis?
By ultrasound abdomen, ma'am.
What is expected finding in ultrasound abdomen?
In ultrasound abdomen, there will be corticomedullary cyst will be present, ma'am. The ultrasound may show normal size kidney or decreased size of the kidney with corticomedullary junction cyst. And
What is the classical sonographic appearance?
salt and pepper.
Kidney. Highly echogenic kidney,
Highly
isn't it?
echogenic.
Highly echogenic kidney. You can't differentiate cortex and medulla. Do you want to see other systems specifically here?
Yes, ma'am.
What other systems you are interested in?
Retina, I want to see, ma'am.
Okay, you want to look at the ocular system. What are the associations of?
Senior Loken syndrome can be associated with retinal degeneration, and Bartle-Biedl phenotype can be presenting as obesity.
What are the abnormalities
polydactyly.
that you are interested in eyes?
Retinal
Degeneration,
retinal degeneration,
colobomas,
and
retinitis pigmentosa.
Yes, ma'am. Retinitis
So these are the
pigmentosa.
associations in various forms of nephronophthisis. Other system which is usually involved along with Kakut,
With CACUT, neurological and cardiac, ma'am.
cardiac. The commonest genitourinary, second most common congenital anomaly is cardiovascular system. So always look for other congenital anomalies in the cardiovascular system. All these should come in your history and examinations, isn't it?
How often do you have a genetic mutation in CACUT?
Around 10 to 15% of patients can have genetic mutations. Sir. Most of them will be like 10% will be due to copy number variations, and 5% can be due to copy number variations. Sir. 5 to 10% due to single nucleotide polymorphisms. Most common is single nucleotide polymorphisms.
Yeah, but overall, so only a minority,
Yeah, 15 to 20%.
only a small minority have these. The rest do not have them. Yeah. And what are the commonest congenital anomalies that you encounter?
Renal dysplasias in males.
Other than in order of the frequency,
VUR, sir.
VUR. So you're
VUR.
talking of primary VUR.
Primary VUR
Okay.
and posterior urethral valves.
Posterior
and,
urethral valve, particularly in males, of course. Only in males.
Yes. And obstructive, like
What kind of
uretropelvic
obstruction?
obstruction or
Yeah,
UPVOs,
obstruction
UPVO
is
obstructions.
Probably
or-
the commonest of forms of obstruction that you will encounter, and you'll keep encountering them even in adulthood,
Yes, sir.
because they're often unilateral
Yes.
and varying in severity. So, whereas the rest of CACUT leads to CKD5 in childhood or adolescence,
Yes.
but
They will.
they
progress.
may lead to CKD or advanced CKD only
Adult
later in
population.
life. Yeah. So those are some of the commonest ones. And can you have reflux along with the posterior urethral valve also?
Yes, yes, sir.
Is it common, uncommon?
Common.
Common.
The
Quite
other
common.
CACUTs usually that can be associated with other phenotypic.
Yeah, when you have one abnormality,
the
you
other
can have,
abnormality will be there
you
in
can have
10 to
many
15%
others
patients.
along with that. So, and the reflux may not be only secondary to the valve. It may be
It may-
primary also. It could be either way. Posterior urethral valve, supposing it is diagnosed well in time and fulgurated soon after birth, what is the risk of CKD developing later?
If in antenatal also, in immediate post,
Fulgurated in time, still going to CKD, what is the prevalence?
it is around 30 to 40%, because valve bladder syndrome may persist, because in the antenatally only the bladder morphology will change, and the valve bladder syndrome will progress and will increase the scars, and if there is intrarenal reflex is there, then there will be progression to CKD.
Any other reason? No scar, no hydronephrosis, bladder normal after reevaluation and after fulguration. Child is associated dysplasia, parenchymal dysplasia.
Dysplasia also, and even reflux may persist after fulguration.
Fulguration.
It's not that the reflux will definitely regress. No certainty of that. So, how do you deal with primary VUR?
Primary view, usually by monitoring as a child ages.
Yes.
The reflex will, the grading of the reflex will usually decrease, because the intramural part of the ureter, submucosal part of the ureter will increase in size,
In length.
and the reflex chance will get decreased. So we will monitor the patient based on the grading of the reflex.
Yeah. So if you know the grading.
Yes, international reflex
Yeah.
grading.
So if it is grade 4 or 5, then what do you do? Is just monitoring enough?
If child doesn't have any recurrent UTIs or any no decrease in renal function, then we can monitor, and based on the age of the child also, less than.
Grade 5 monitoring. So when will you think of doing a surgical correction in VUR?
Surgical correction, very young child, and if they
Very
are
young
on
means?
less than 1 year, no? And even on prophylactic antibiotics, there is a breakthrough infections, recurrent breakthrough infections, and
Generally, grade 4, grade 5 are indications for surgery.
Surgery.
Up to grade 3 is what you are saying, that you
Don't
give
have a-
prophylactic antibiotics, monitor if there are breakthrough infections, then you may consider surgery or some intervention. Otherwise, you just continue prophylaxis.
And if there are new scars formed on follow-up,
Yeah.
again you have to do surgery.
You have to do surgery.
Parental anxiety. If the patient is not keen with the prophylactic antibiotics, all these are some of the other indications for surgical correction. Now, what is the optimal treatment for this child with CKD-G5?
premature transplantation. If
So what
she
are the
was
problems of transplant in pediatric age group?
Steroids may cause
Pre-transplant, donor
age, low sensitization will be more, ma'am. Low
Yeah.
age, large. If there is discrepancy between the donor age,
accepting a live related donor. Any issues?
genetics should be
What are the indications for genetic study?
child presenting. If there is any family history, if there is any associated anomalies associated with this, and sibling having
What is the pattern of inheritance in this nephronophthisis?
nephronophthisis is autosomal recessive. Ma'am.
Autosomal recessive. Okay. Then what other factors interfere with your transplant program?
And the risk of steroid toxicity and immunization, immunosuppressive toxicity, we have to assess. Ma'am. The growth and-
Intraoperative.
Intraoperative.
Any size disparity, will it produce any
yes.
problem? Iliac fossa will
Yes.
be very small, may not accommodate your large kidney of the mother
Disparity
or
of
father.
what?
Kidney size.
One is kidney size, and what about the
Vessels.
Artery vessels.
artery?
Vessels.
Yes,
So-
that's very important.
More of thromboembolic complications in the post-transplant period. Then
And we have
immediate post-operative period, what are the problems that you encounter? Volume management of pediatric transplant, day 1, day 2. Assessment of graft function in the first 48 to 72 hours of transplant. Any issues?
urine output.
Can you rely upon the serum creatinine? Other problems?
Electrolyte abnormalities, we have to
Immunologically?
immunological. If age discrepancy between the donor and recipient is more, then a high immunological risk.
Do they metabolize drugs slower, faster?
Hospital.
Do you
Faster.
want to change the schedule of your tacrolimus?
They require more immunosuppression or less immunosuppression?
More immunosuppression.
More, yeah.
More immunosuppression.
Why?
Because children, since
They are immunologically active. And what about the metabolism of tacrolimus in pediatric age? Do you give twice daily or thrice daily? Requires thrice daily dose,
Thrice.
isn't it? Thrice daily dose.
Faster metabolism and thrice daily dose, yes.
Problem with the steroids, isn't it? Pediatric. Then
Growth problems.
growth. We have to monitor the growth.
You may consider steroid
Free
withdrawal
protocols.
or steroid-free protocols also
both
in
steroid
them.
protocols.
Yes.
Which is the best steroid protocols in pediatric age group? If at all you want to take out steroids,
Alternate day?
that is steroid free regimen, steroid avoidance protocol and steroid withdrawal protocol. You want to take out steroids, which is the best time to take out steroids after transplant? No steroid at all at first week, at 3 months. First week.
First
At
week.
the end of first week, you have to stop if you want to stop.
When you're counseling the parents of such a child, what is the most important thing to tell them about when you're counseling them about transplant? All this which Madam has discussed with you, this is all important, no doubt. But what else? One very important fact that needs to be conveyed.
Most common cause of graft dysfunction.
Non-compliance,
During adolescent period.
yeah, certainly is important. It's important in all age groups and in adolescence, as you
adolescents,
said,
it will be
problems with
non-compliance is the most
compliance. But one very important issue is, even if you have a successful transplant, what will be the lifespan of this patient?
Around 15 to 20 years. After that,
15 to
second
20 years.
transplant.
So,
Second.
is that the
there is-
lifespan of a normal individual? No.
there is-
So, to achieve a normal lifespan, you may require maybe 3 kidney transplants
Yes.
during the life of that patient if you want to achieve a normal lifespan and if those kidneys function for a good length of time. So, that's a very, very important thing to tell the parents. Now, just one transplant is okay for the time being, but what about
She may need
the
another.
future?
So will you accept the grandparents' kidney for the child?
If first.
So parents can be reserved for the
Reserved for
second
the
transplant.
second transplant.
Isn't it? It is as per the legal, also this live-related donor transplant.
Yes.
Grandparents and have
They're
been accepted as the live-related donors.
Okay, I talked about accepting a 70-year-old recipient for transplantation. What about taking a donor who is 70 plus?
Expanded criteria. Donors.
A donor.
Accepting
like
a donor
grandparent.
who is more than 70 years of age.
You can, yes, you can. Provided there is no cardiovascular disease, no history of stroke, no increased risk of stroke, no other risk factors, hypertension, diabetes taken care of, you can. In fact, I would be more willing to accept an elderly donor than a 20-year-old donor. You know, because a 20-year-old has to live 50 years more. The 70-year-old, if he lives 15 years, good enough. You can't live longer than that. So a 70-year-old can also be accepted for as a donor.
What are the long-term problems of kidney donation then?
Efficacious mode.
Loud and clear.
Actually, according to the risk of renal failure will be less than 1%.
No, you're talking of
Long-
donors or recipient?
Donor problem.
Donor. The question is on donors. Do you know of any study which compared kidney donors with a good
General
control
population.
group, and then they did long-term follow-up? There is a study by Dori Segev, not so recent, but a very good study. So what was the risk of mortality, all-cause mortality, cardiovascular mortality, ESRD in those donors? Was it same? Was it increased?
Same, sir.
No. All cause mortality and cardiovascular mortality, the hazard ratios were 1:3, 1.3, 1.4. So somewhat increased, but not too much. But the risk of ESRD, 11.38. So there is a definitely increased risk of ESRD in the long term in donors. And most of that ESRD, these were live related donors mostly, right? So most of that was due to genetic reasons. When they analyzed the cause of renal failure in those, mostly genetic. So generally when a family comes to you in the OPD and they ask, are there any risks to the donor? And we generally take it lightly. We say, no, it's all right. One kidney is good enough for a lifetime, and so on. But it's not actually true. If you seriously go into the details, this is the data.
Females before completing their family donating one kidney, any problems during the pregnancy?
Risk of PAH when pregnancy induced
Increases.
hypertension increases.
Increases. Why does CAPD lose its efficacy after a few years?
The membrane characteristics will change over time due to the high glucose concentrations, and there will be fibrosis, and the effective peritoneal surface will decrease over time. So
What happens to the blood vessels there?
the blood vessels, there will be myofibroblast, fibrosis, and neovascularization.
Neovascularization,
will happen.
yes, there's angiogenesis,
Angiogenesis.
neovascularization, as well as increased thickness
Thickness of the vessel.
of the peritoneum also.
Yes.
Of the peritoneum that will occur, and that will interfere with the efficacy of the procedure. And,
Thank you, sir. Thank you.